Welcome to Collage of Health. Thanks for being here today. Collage of Health is all things from the mind, body, spirit. And today I'm going to focus on a widely known disorder that that's been quite, tragic in terms of its death and disability in not only the United States, but worldwide. And bipolar, as it's now known, used to be called manic depression. And I can remember when I was a kid, my mom had a friend who actually had children who went to school with me. And this childhood friend that was my mom's had manic depression, as it was called back then. And I can remember my mom saying that she had this debilitating depression that responded to lithium as if it was a magic drug. And it allowed this woman to be functional within her, her family and her friendships, etc. And my mom wasn't a good friend of hers, but she was friends enough to see her over the years and to see that this was true, that this medication really helped her significantly. And this friend of hers eventually did have kidney failure, which is the biggest drawback with lithium is it's metabolized through the kidneys, which most drugs are metabolized through the liver. This one is metabolized through the kidneys and unfortunately can affect kidney function, and in the long term often does cause kidney failure. So that was my first experience hearing about manic depression, bipolar disorder. The second time that it came into my periphery was when I read a book in high school called Lisa Bright and Dark. And it was about a teenager who had bipolar, manic depression, and how it really affected her and her mood swings and what she did when she was in a psychotic manic state. And it just seemed, I don't want to say scarring, the book, but it was very upsetting, but also kind of intriguing. Like, what was this disorder that could overtake someone to the extent that they became so different from who they were? And then fast forward, I started working in psychiatry as a psychiatric nurse, RN, back in, I think, 1988, around 1988. And I've worked over the years in many different settings as not only an RN, but then later as a nurse practitioner, taking care of people bedside and also in the office prescribing medications. And I mentioned in the video on methylfolate, the MTHFR gene, that there are biomarkers for many different psychiatric issues. And there are also biomarkers to lend to people who are more prone to neuroexcitability in the brain. And so we have these ions in our body. We have sodium and calcium ions, which cause what's called depolarization of the cell. So it activates the cell. And then repolarization of the cell occurs with opposite ions, potassium, for example, where the cell is at rest. And so with bipolar disorder, what it's kind of in some ways, and this came up years ago when they started to use seizure medications. I can remember when I worked inpatient in the 80s, it was like state of the art where people were starting to look at drugs beyond lithium. And some of those drugs were seizure medications because with seizures, your brain is firing beyond its need or capacity to fire, where it just causes excitability. And that's what happens with bipolar disorder, where it's firing at such a rate where people are off. They become manic. And with mania or with depression, there's this imbalance going on, obviously, in the brain. And however high, I used to say to my clients, however high you go up, that's how low you're going to go down. So if you're like in that manic state, just know that there's going to be on the other side an experience. Because in some ways, mania or hypomania is a pleasant experience for people, especially people who have been depressed, when they're feeling on top of the world, like they don't need to sleep, they don't, need to eat as much, they just have all these creative thoughts. And then unfortunately, the other side of it is like this sense of dullness and darkness and depression. And throughout history, I'm not going to name all the people who are famous who've had bipolar. I don't actually have them at the tip of my tongue, but I can put them in the notes. But all these geniuses in our history had this creative pulse because they've been in a state of at least hypomania, where all these brilliant ideas come to them. So in some ways, it is like the brain is having a seizure to one extent or another. And I actually just looked at the research about this. And, these calcium channel firing happens in this meta-analysis when people are untreated with bipolar disorder. And it is shown that lithium in this meta-analysis can help decrease the calcium channels, and that's probably where its effectiveness happens. The newer medications, some of which are seizure medications and atypical is what they're called, psychiatric medications or typical antipsychotics, they work to a lesser extent directly on these calcium channels. So from a physiological perspective, that's what's happening. Now, this is where the bipolar 2 marries with trauma. When someone's had a lot of trauma, of course, they're going to be hyper vigilant, and their brain is going to be firing vigilantly to say, be careful, watch out, bad, scary, unsafe. And then that is what happens with trauma is trauma begets trauma. So trauma is an ancestral disorder. Trauma shows up ancestrally in the same samskaric patterning. And who knows why, from a high vibe perspective, maybe so we can get it right, we experience trauma so we can kind of get out of that samskaric loop. I can tell you personally with trauma that I've had, a big piece of my trauma has been with car accidents, which started when I was 2 years old. And I can remember like trauma begetting trauma. One time I was in a car wash and the person behind me accidentally put their car into drive and they rear-ended me. And I thought, well, there you go. I mean, it's not like it was my fault that this happened, but I almost had this like radar, like trauma car accidents where this car, ran into me. So I'm not implying that trauma is people's fault, that things that happen to them are not their fault. But I am saying that there is a attraction with trauma where it does repeat itself. And it is actually known that it repeats itself ancestrally. And so back to the brain. With trauma, the brain is firing more than it should be. With bipolar, the brain is firing. Untreated bipolar, the brain is firing more than it should be. Interestingly enough, with the heart, there's a correlation between the heart firing more than it should be from a calcium ion perspective. And there's medications called calcium channel blockers for the heart, medications like verapamil. Now, it's experimental if these medications can help the brain. But I'm betting if I went back into psychiatry now as a prescriber, I think I would start to look at prescribing medications off-label for bipolar that had to do with, especially obviously for people with hypertension. I'm not going to prescribe it for someone who is hypotense, where their blood pressure was low. But there is a correlation potentially in this meta-analysis that I was looking at between the heart, high blood pressure, and bipolar disorder. It's even more interesting if we want to go down the rabbit hole with Ayurveda medicine, 5,000-year-old medicine. There is something called Sadhaka Pitta, which is the heart and the brain. The part of a subdosha of Pitta, which is the brain, the gray matter of the brain and the heart. So we know that there's this heart-brain connection, the mind, the brain, feelings, thinking. So I think as we go on with research, we're going to recognize that our organs are all interconnected. And when we treat one piece of us, we treat another piece of us. If we treat trauma, then we're in part helping to downregulate the potential for a bipolar event if we get at the trauma early enough. So these are some of the things that I wanted to put out there. So with medication, so I'm going to just talk about lithium and Lamictal, actually two medications that I found. I'll talk about a couple medications, but with lithium, what I found was it worked for especially for bipolar 1, where people had discrete manic episodes and with depressive episodes. So for bipolar 1, people have to have had at least one manic episode. And I don't have the DSM-5 in front of me, but they have to have had mania, they had to have depression. I found lithium to work. I also found many people who I inherited when I first went into the field of prescribing at outpatient clinics. Many people were over medicated. And I found that given it's cyclical, you don't have to medicate in the same way to the same extent that you would when people had an acute episode, which this is no like big you know whatever, big news story or whatever you want to call it. It's not this like, yes, many practitioners will say, oh, of course, when someone's acute, you're going to prescribe a higher dosage. And if they're, chronic, you're going to prescribe it a lower dosage. What I found when people were chronic is they were over medicated even still. The tough part though so with lithium, you need to let someone know that, eventually there's a potential for kidney failure, and you have to monitor the panel, the renal panel, the kidney panel very closely and look at markers for kidney failure frequently. So that's one of the things with lithium. Another thing with lithium that you need to be careful of, if you are lowering the dosage, you want that sweet spot. So you want that part where the person feels alive and creative, but you don't want them to be so low on their medication that or you want to tell them, we can go low on your medication. I had this one young girl who I saw who was beautiful and tragic. I mean, she had classic bipolar, and she had a family member who had classic bipolar. And I don't want to kind of give too much of the details because, for confidentiality reasons, but this young girl was diagnosed with bipolar at a very young age. And when she was manic, she did bizarre things, dangerous, risk-taking, bizarre things. And when she wasn't manic, she was the most delightful, wonderful person. And it was really hard because she didn't want to be on medication. And she was a great responder to the atypical antipsychotics. So these are a classification of medications that came out most recently, if we're looking at the trajectory of psychiatry. And they're not recent for today's recent, but they're, in the last, I don't know how many years, but it's more recent than lithium. And they work wonderfully in many instances for depression, psychotic disorders, very treatment-resistant depression, psychotic disorders, etc. The problem is people gain these huge amounts of weight and they become diabetic and they have hyperlipidemia, high cholesterol, where they have a metabolic crisis or condition. And, who wants to, have this as a side effect where you're a normal weight and then you're obese and you have trouble losing the weight because of the medication, and it's a real thing. Now, some people, you can look at biomarkers, are people at risk to gain weight with this classification of medications, which can kind of spearhead a conversation like, do you want to go down this road or this road? Someone has a family history of kidney failure and they're a low risk from a biomarker perspective for these second generation atypical antipsychotics, then you're going to go that way. Conversely, if diabetes runs in the family, you might want to steer towards lithium. So that's what's beautiful about individualized medicine. Anyway, back to this client. She was not at high risk for gaining weight. She didn't gain weight on the second generation atypical antipsychotics, such as Seroquel. She didn't want to be on them though. So we had this agreement, not only with her, but also her parents, because she was a minor, that if she noticed that she was not sleeping as much, so sleep is the biggest precursor for mania. That's where you see it first, when people start to not sleep as well. And that's where some of these atypicals come in, like Seroquel, is they're very sedative. So it really helps people sleep, which indirectly responds to help control this disorder. Whereas lithium is controlling it directly with those calcium channel blockers. So anyway, she had a few events over the years that I saw her, nothing like the initial event, which was horrible. It was just really horrible, the risks that she was in. And, at first her family was in denial. And, there took some convincing that your daughter has this chronic issue that she's going to have for a lifetime that's going to need to be managed. There is a school of thought, which I do believe is true, that unmanaged mental illness can create a worsening of condition than if you manage a condition early. And that's just a given with all disorders. If you don't manage it, it's going to get out of control, and the brain, there's going to be brain changes, I believe, if you don't manage conditions. I can think of another client who I had, and he was just a really incredibly intelligent, gifted, and renowned, actually, individual. And he had his first bipolar event, manic event, in the spring in the hot sun. And that's one of the things that can trigger mania, is the sun and spring and warm weather, because it fuels the brain in such a way, working with these ions, where people are less likely to sleep. And so then they can, have this event. So there's many precipitants. Precipitants are things that would lead up to the first event with a disorder. It could be going away to college. It could be a breakup in a relationship. It could be the sun. It could be drugs, biggie drugs. Marijuana, I've seen psychoses with marijuana, but when you're looking at bipolar, things that are gonna fuel the neuro excitability in the brain, like cocaine or stimulants or things like that, that can lead to an event. Um, Trying to think of what else, a divorce, the birth of a child. When people are pregnant, there's some kind of protectant with mental illness, but that just ends the day that baby's born. And I've had clients who have had bipolar, who have a child, and that has spurred mania and bipolar, a psychotic event. And that's known in the literature, that's common knowledge that postpartum is a big risk for postpartum psychoses, which is often bipolar. So with bipolar, you want to tickle out, is it bipolar? Is it schizophrenia? If someone has cycling, if they have cycles of moods, cyclical moods, it's going to probably be bipolar. Where schizophrenia, it's going to be more like a flat, people might have episodes, but when they're not having an episode, they don't necessarily tend to go into a deep depression. The risk with bipolar is suicide. There's a high rate of suicide in bipolar disorder. I think more than any other disorder, because as I said before, like when people go high, that's how low they're going to go. So, it's really important to treat this disorder and the depression. Lamictal is a medication that is, from my perspective, a wonder drug for some people. 4 out of 1,000 people have a serious reaction to Lamictal, which could result in death. It's called Stevens-Johnson syndrome. Excuse me. Stevens-Johnson syndrome, and it can occur with many different medications, like certain antibiotics and, even Tylenol, Stevens-Johnson syndrome can occur with, but Lamictal has gotten a bad name for it. So there is a black box warning around this medication to be careful if you prescribe it. That being said, it does seem to help people not only with bipolar 1, managing the depressed period of the disorder, but also with bipolar 2. I've found that people who have trauma, some borderline personality issues, and bipolar 2 issues with the cycling, cyclothymic episodes, hypomanic episodes with depression, they seem to respond really well to Lamictal. People with treatment-resistant depression as a single disorder also seem to respond well to Lamictal. One of the important things with Lamictal is that people do get their B vitamins in. And as I mentioned in the MTHFR video, you want to be careful. You don't want to overmethylate. You don't want to get those B vitamins too high in the system. So it's definitely a dance. So back to the gentleman who had the bipolar event that was triggered by the sun. He was kind of similar to my other client, where when he had these episodes, he needed medication and his brain needed to come down. But he was able actually to live almost on no medication at all between events. But we had a contract. You have to let me know as soon as you stop, as soon as you have any changes in your sleep. So sleep is the biggest precursor to an event. And people need to be sovereign in their care. And, as I mentioned in a couple of my videos, I had a practice where people were responsible for their health and we worked together. And if they weren't willing to work with me in terms of collaborating, then they probably weren't the right client for me. Unfortunately, both of these clients were the right client because they were willing to, to say, hey, I'm starting not to sleep, or, I'm feeling these changes, I'm getting revved up. And that's where it takes a village. That's where, because hypomania feels good, people often need their wives or their parents or their friends to say, hey, you seem a little off, or it's everything okay, or I notice you're not sleeping, where they could really help that person say, I think we need to raise the dosage of my medication. And if you're working with people who you're lowering the medicine just to that threshold where they're feeling alive but not hypomanic, or even slightly above that threshold where you can go in that window, there is a risk. I mean, there's definitely a risk. The risk with mania is more to others than to the person, because manic people can go on stealing sprees, shopping sprees where they put themselves in financial um, bankruptcy, worst case scenario. They can drive their car fast. They can be scary. Someone who's manic is scary. I remember working inpatients on an inpatient unit, and there was an older man there who he was in his like late 80s, he might have been 90. He was a little guy, but he had this manic episode and he was the strongest person around. And he was holy terror on the unit. So it's it's a tricky business. Psychiatry is a tricky business for not only the client, but the people who love them, and, the caregivers. And it's so easy from a caregiving, prescribing perspective to snow someone and to say, well, we're just going to manage you and over medicate you so you just can go in a corner and behave. But most people are not going to be compliant with their medication if they're over medicated. And I think that's where it can also be tricky, because people, certainly the onus is on them and there's no liability if someone like is not taking their meds. But there is a cost to the same cost where they're going to get manic and they're going to cycle and they're going to be caught in this samskaric pattern of not being compliant with medication because they're being over medicated, and then ending up being manic or depressed and being hospitalized or committing suicide. So if you can work with people intelligently and mindfully, and if people are willing to take responsibility for their health, from my perspective, that's the best way to go. I just tend to look at my notes to see if I wanted to say anything else, and I think I said a lot. If you have any questions in general about this disorder or my experience, please put them in the comments. Or if you want to share any kind of firsthand or secondhand information around this, I'd love to hear from you. And if I think of anything else, maybe I'll put another video out there. So thank you. Have a good day.